Thank you, and thanks for inviting me. So when I first got the invitation from Borsica, I thought I would present some standard, here's 101 ways to collect implementation cost data and 101 ways to analyze it. But given it is the afternoon, I thought for sure I'd put you all to sleep. So instead, I'm going to present a really cool project that used some economic analyses, I guess we could call it that, Joanne, right, to demonstrate how the analyses inform the implementation or further implementation of the intervention. And probably the person who should be giving this talk is Joanne Shoup in the back, my colleague, who actually was key to conducting both the evaluation of this project and the economic analysis. I was more like, by the way, can you talk to me once in a while about how we're doing this? So again, kudos to the team who really pulled this off, but I think it's a very, very cool example. So real quick, background on this, as many of you in the room are involved with primary care and other public health initiatives, influenza is a big deal, and it has a particularly significant effect on those with morbidity mortalities, especially around asthma or COPD. Back to technology and other uses of technology in population-based care or even in integrated care systems. Interactive voice IVR technology, interactive voice recognition software has been very successfully used in preventive initiatives, and we are using that on a regular basis at Kaiser Permanente to collect patient-reported outcomes. And that feed into our medical record. Just a little tickler there. But the objectives of this project were to evaluate the effectiveness and costs of an IVR initiative for flu vaccine reminders targeted toward a chronic disease population. The population and setting and context, and again, Joanne, I'm looking for corrections if I misspeak here, but it was adult members at Kaiser Permanente, Colorado with asthma or COPD, the influenza vaccine outreach initiatives of the fall of 2012, and the stakeholders are listed here. Specifically, our Department of Population and Preventive Services, who do the population-based outreach to our over 500,000 members here in the Denver metro, Denver-Boulder, Colorado region. Our chronic disease managers, who are intimately familiar with with the characteristics of the target patients. Primary care departments, who were very interested in how this would work, and our group at the Institute of Health Research. So back to the basics of D&I, selecting your framework. What were the outcomes of interest that we needed to evaluate? And in this case, it was effectiveness, effective of the various arms of the intervention, and costs. What were the target populations, as noted, asthma, COPD, participation? So our outcomes that we wanted to look at from that perspective were proportion contacted versus proportion vaccinated, and how representative or how were the patients identified and or recruited. And in this case at Kaiser Permanente, because we do have such amassed billion-dollar electronic medical records and registries, etc., we can identify them either through our chronic disease registries or more specifically, your membership records, or if you're enrolled with Kaiser Permanente. Choosing the study design. Who delivered in the case of an economic evaluation, these are the key issues that I always try to emphasize if you're really going to be able to understand what are the resources involved with implementing that intervention or implementing the initiative within the population. Who delivered the intervention? What were the training and supervision that were needed? What were the characteristics of the staff? What kind of training overall was required? Is it a nurse? Is it a doc? Is it a public health worker? Is it a community health provider? What were the characteristics? Because in a minute I want to talk about sensitivity analysis and how can the characteristics, either in the personnel or other, be changed or adapted or substituted? What were the components of the intervention that were delivered by specific staff? How long did the intervention take? What was the time span? Or another example is if it's a face-to-face meeting, or if it's a one-on-one intervention, how long was the session with the participant? Because that's important to figure out what the cost was. Not only the cost to deliver the intervention, but whose cost from the perspective of either the health plan or the patient costs. If it's so expensive, if it's so expensive to the patient, not only in the resources to buy the different food or the exercise equipment, but if I have to spend an hour driving across town and another hour waiting to have a session with somebody and then 2 hours driving back, the time cost alone to the patient may be prohibitive for allowing the intervention to be successful. And how do the intervention, and this is key here, how do the intervention costs change in a different replication scenario? So change in characteristics of the target population, change in technology. And this is the key that I'm going to showcase, I guess, today. Back to study design quickly, minimize the burden on both the subjects and the research staff. So through many of the behavioral interventions that I've been involved with where we try to capture, we have been successful at capturing intervention costs, it had to be a pretty minimal, modest instrument. So back to Russ's example, instead of 440 variable or questions that can be internally validated, you want to make it simple. We actually did the cost analysis at one point. If it exceeded more than 5 minutes a month for the staff to report their involvement in the project, we weren't going to be able to collect those data. And capture all resources and costs that would be required for future implementation, and differentiate those from the research and development costs. You know, if somebody asks me, why would we need to cost this out? You have your budget from your R01. Well, how much time is spent, especially in the front ends of most intervention project or large intervention projects, where it's the investigators coming up with the different instruments, thinking great scientific thoughts, IRB, consenting. What would you need to keep this intervention going in that setting or in a different setting versus what are the research and development costs? So I think I did say, and identify resources and costs that would vary in different scenarios. That's what I'm calling, in this case, sensitivity analysis. Excuse me. Primary outcome in this case, incremental. Economists use marginal, but I've been trained not to say marginal and instead use incremental difference. Incremental change in proportion vaccinated in this case. Total cost by intervention arm. Postcard versus IVR versus IVR plus postcard. So again, this was a randomized clinical trial of 3 arms: postcard, IVR, IVR with postcard. And incremental costs per incremental change in the outcome of interest. In this case, we were hoping to look at change in the proportion vaccinated per change in cost. Most other large cost effectiveness analysis often use the other metric that many of you have probably seen before, and that's quality adjusted life years saved. And I'm not going to touch that today, but I could go on for a few hours about my fondness of that measure. But I do put up some references on that metric at the end of this. Sensitivity analysis, change in target population, personnel, substitution of personnel, doc versus medical assistant, and I think that would be the case maybe in some of the other examples given. Change in technology use. How am I on time? Okay? Okay. Have the stakeholders involved. In this example, the stakeholders came to us. So it was more about us being open to being engaged by the stakeholders. And we were very lucky in that they were involved from thinking of this intervention, wanting to make a change on how they targeted flu vaccine reminders, to helping us be informed about what what could be changed in the intervention for the sensitivity analysis. And because of their level of engagement, they were very willing to participate with the efforts that especially Joanne took on about capturing the resources and costs associated with the different strategies. So stakeholders are key. Findings, 12,285 were randomized to the 3 arms. And I'm not going to, I do have the second bullet, and we have more data on that, or Joanna has more data on that, that there were no differences in the outcome of interest. There was no differences in the proportion that were vaccinated. But older age, outpatient visits, prior receipt of vaccine, being an employee or a dependent, were positively, employee of Kaiser, were positively associated with receiving the influenza vaccine. Here's the interesting piece. Here are the total personnel costs by intervention arm. Note, boy, look at that IVR. That's awfully expensive. Then we looked at software, hardware, and supplies. Boy, look at that IVR arm. It's almost as expensive as the other one. But I highlight the green line there. That green line is IVR T1 line, one telephone line. So backing up to personnel, for the IVR, we had the health educator help inform us about things. We had the database administrator to identify the patients, and that code, that SAS code or whatever code that wrote who are we going to send it to, didn't matter if it went out to 12,000 members or 400,000 members. Didn't change the time that database administrator or a program manager or data analyst worked. Informatics on how to push that out into the IVR world. The internist that helped inform medical issues. Voice talent. That's not going to change. Person only says it once for that 12,000. So again, back to hardware, software. So total cost per member in the group. Look at that IVR. It's awfully expensive. But what happens if we wanted to implement it to either everyone who is a target cohort for influenza vaccine? Kids, pregnant women, the elderly, those with chronic diseases. What if you wanted to push it out to 100,000? Or more importantly, what if you wanted to push it out to your whole membership? It was 5 cents per member per month. And and I know Joanna's messed around with this inside out and backwards. So this is where we demonstrated that if you look at your sensitivity analysis, if the outcome doesn't change between arms, that isn't the only thing to look at. Look at the economic impact of it. Look at the cost associated with different scenarios and how the implementation characteristics could change. So as noted in that arm, the findings were more expensive per member for the intervention, but the sensitivity analysis demonstrated it was more effective to use the IVR. And my punchline here was IVR was pushed out to our entire membership this fall. Lessons learned: engage stakeholders, engage stakeholders, and engage stakeholders. In our case, in our research group that's embedded in a health plan, be open to engagement. And that's often what we have trouble with, finding the time saying, yeah, I have time to listen, not as, gosh, can I charge this to my other grant, but to be open for opportunities to conduct these kinds of, help them conduct these kinds of evaluations, and they could often lead to ideas for even better ones. In our case, I think we discussed it would have been really cool to have a flat, zero, no intervention arm, but we couldn't do that. As standard practice, we always send out reminders to target populations. And I think another one we ran into, identify all resources needed for the arm prior to implementation. We were, especially with the phone lines and the servers, weeded through, Joanne weeded through a lot of different issues around that after the fact. And consider, we didn't talk about or measure what would happen if we sent them multiple calls, multiple very inexpensive IVR calls. And again, I put up some references for both background on cost effectiveness, different places, different instruments to capture intervention costs. So they're all there. Thank you very much.